So I work at UC Davis, which is, an urban academic hospital. We have a level 1 trauma center for adults, level 1 trauma center for peds. So definitely have an academic practice. I was very and have been very involved in my state chapter for a number of years, was past president of California ACEP, and really focused on kind of our state issues. But really have started to realize with the balanced billing fight that we started to have, and then everything that happened with COVID, that we are at an inflection point, I feel, as a specialty. There's so many challenges out there for us that I just felt like now was a time I really needed to get involved with National ACEP. So here I am. I was told, it's a real challenging time, and so I felt sort of called to do this at this moment. I'd previously thought that I would wait longer, but I just feel like we're at such an important point that I needed to do it now. So here I am.
Okay. Well, let me introduce who we have on the call with us officially. This is Cameron Oderog, our president-elect, and Todd Parker, our secretary-treasurer and legislative chair.
Great.
So,
Todd, like me, you can get really consumed in state issues.
Oh, yeah.
Oh my gosh. Yeah.
We'll have a lot to talk about.
Yeah, no,
that's been my life.
Yes, state issues have been my life. Our state, so for my part in California ACEP, I've done a lot in terms of substance use and behavioral health disorders, but really we've focused on funding from the state. So over the past couple of years, I've gotten about $40 million from the state to go into emergency departments, just public money to help treat people with substance use disorders. They've been giving us money because they've argued that we're an important public health entity. And then our state budget came out 2 weeks ago, and they were going to cut my funding for my emergency departments with another $20 million. So we're in the process of getting that back. But yeah, all consuming. But then at the same time, when I think about where we need to go, I think the states are really good examples of how we need to evolve and what we need to do in the future for our specialty.
Yeah, we've been in the fight with all of this. We actually have a very favorable legislature when it comes to things like mental health and the emergency department information exchange and those types of things. We've had good success with all of those things, but like everywhere, the money stuff is a battle. And we won a big battle on the out-of-network billing this year. So we were able to implement an arbitration model similar to Washington State. We are very fortunate in Virginia that we have an all-payer claims database that is a good one. Apparently, we're one of the few states that actually have a good one. So we were able to tie a lot to that. It's been, like everywhere, a 4-year, 5-year battle where, we were on the brink of disaster and then managed to pull ourselves back from the brink. I mean, we literally this year in a committee, the vote went against us and went for the health plans bill, which is, median in-network rate. And then one of the people realized that they'd voted the wrong way. And so they called it back up to a vote. It went to a revote. And I think there was so much confusion, and we won by 1 vote in the revote in the committee. And I mean, it was like that. It was like we were dead. And then all of a sudden we were alive. And then all of a sudden, we got our bills through, and that was great. And then, which, Cameron, I haven't updated you as much on this in the last day or two, but at the same time, they snuck a budget amendment through that downcodes Medicaid's for the, avoidable ER visits list down to a level 1. So any level 2, level 3, or level 4 gets downcoded to a level 1 if it meets this avoidable list of ER diagnoses. And so, and that got signed by the governor, who is a physician. And actually, we had a similar program 5 years ago, which we were able to get rid of. And it was actually a very small program, not nearly as comprehensive as this one is, and we got rid of it. And he actually helped us as the lieutenant governor get it through and find the money in the budget. Because as you know, whenever there's these things, you can get legislators to agree with you, but if there's money associated with it, they can say, yeah, that sounds great, but there's no money for it. And so we got the money for it. So that got put in place. That's going to quote unquote save the state about $70 million. About 14 million of it would be out of emergency physician provider reimbursements, and the rest is it actually includes the hospitals too. So that's why we have a strong ally there. Their facility fee would get down coded to a level 1 also. So anyways, we're fighting that. The good news is with the help of EDPMA, and I'm also on the reimbursement committee for National ACEP. We were able to find out and get the blueprint for some other states that have had this, specifically Kansas. And I don't know if you guys have ever dealt with a Medicaid downcoding in California, but it violates CMS conditions of participation. And there's been multiple rulings by SEMA, Burma, et cetera, that you can't do this. So we're going that route right now. We've drafted all the letters and we're floating them. Fortunately, our DMAS in the state, our Department of Medicaid Assistance Services in the state, is actually sympathetic to us. They did not want this program. They did not ask for it. And now they're in charge of implementing it. So they're actually working with us. So we'll see. But it's fascinating. Cameron, why I've got you on the call. I was on this call yesterday and a light bulb went off. The diagnoses that are on this list are status asthmaticus, diabetic ketoacidosis, hemorrhagic. There's diagnoses on there that are like, you're like, wait, this is an avoidable ER visit, and a light bulb went off yesterday, which I don't know why. This is probably obvious. This list of diagnoses, which I now have, they really are. They're avoidable ER diagnoses if the patient is being managed properly from a primary care standpoint, right? Diabetic ketoacidosis is theoretically avoidable because, if they're not being managed as from a primary care standpoint, they can go to DKA.
Preventable, not avoidable.
Yeah, or preventable, right? They're preventable, right? And so, we actually were going through these diagnoses with the people yesterday and saying like, so wait a sec, diabetic ketoacidosis, that's going to go to the ICU, and you could see even a light bulb go off in their heads too, that they're like, well, this is ridiculous. So, anyways,
yeah.
So that is our life. That's our life in Virginia.
Yeah. You fire up the patient rights groups and yeah.
So, well, thank you for your work. We've actually spent a lot of time.
Right.
And we've spent a lot of time countering. California, if I hear the name California one more time from our health plan lobbyists, why can't we just be more like California? California has 125% of Medicare, and that works really well. Their emergency departments are thriving.
We exempted ourselves out.
I know, we say that all the time.
So California has that, but we are not included. So they had, the grand bargain, and at the last minute, we had some really good champions and just pulled out. So we're exempt. But it's a tenuous situation because now we have no allies to fight with us because we're out there all by ourselves.
It is. So are you immediate past president of California ACEP now, or are you?
No, I was immediate past president last year. So I have been out for, I think, 2 years. It's all a blur.
Okay, good.
But
okay,
yes.
Well, if you were in that fight, if you were in that fight, you know what it is. You know what it means.
We have been fighting, it's a different tactic, but it's been decades. It has literally been decades. And they come up with new and creative ways to cut billing, and it's, always fighting with the insurance companies. So I've learned very much about framing. I never, ever, ever talk about avoidable ED visits. And you are correct. A lot of times we are our own worst enemy. Our members out there will talk about avoidable ED visits. And I always try to there are some visits that would be preventable if they completely funded the primary care system, but particularly for Medicaid patients, that does not happen. And so we need to be there to pick up the pieces and save lives, and we need to be fully funded as part of a public health system. We're now talking a lot about, particularly given the way that the conversation has shifted nationally, and never have we been on display in a better light in terms of our role in public health, that we have kind of shifted a little bit to talking about emergency medicine as an essential public service, particularly our rural areas. So in California, there's a lot of very rural areas, a lot of critical access hospitals that are really at risk. And so communicating that having emergency physicians and keeping their doors open is really part of the public health system, and the whole system will collapse without having that 24/7 access. And really, the state needs to fund emergency physicians and emergency departments as part of the public health system, that in some way we need to be like fire and EMS, and that they need to have funding to keep the doors open. We need to have capacity funding. So that's kind of how we're trying to shift. But yes.
How well do you feel that National ACEP supported you as California ACEP through a lot of these fights?
Mixed. I think for California, I think from National ACEP, I think we got the balance billing fight many years ago, many years ago, before anyone else was. So we started to raise the alarm probably 10, 15 years ago. And it was a conversation that National ACEP did not want to have. I think nationally, a lot of times there's a tendency to think that, particularly for California, we're out there on an island. And a lot of times I think they that they can just put a wall around California for the rest of the country. And so that's a
lot of California wants to put a wall around itself.
But I think there's kind of a vision of like, hey, that won't happen to me. And I think that, ACEP as a whole tends to try to protect vested interests and has a hard time sometimes seeing future threats. And really,
I agree.
It's the state chapters. This is where you can see what comes from the state chapters. And because state leaders like yourself are so deeply invested in what's happening in the state, you really understand all of the issues, and you learn how the conversation goes because you're so closely invested into it, that I think sometimes National ACEP really needs to do a better job of learning from the state chapters. Both supporting, but really learning from the state chapters. Yeah, and I think it's a mix, right? Because there are some smaller state chapters where ACEP really does, and I've heard from smaller chapters that ACEP does a great job of supporting their state chapters. The ones that don't quite have the resources, the ACEP does a really good job. But because they're used to that relationship of kind of top down, they do a less great job of learning and supporting the larger chapters, the chapters that really have the infrastructure to work within their state legislature. So I think that flow needs to be more two-way. And Sarah, I'm sure you probably have thoughts about this as a executive director. I know my own executive director has a lot of thoughts on better flow of two-way information. But I just think that it's a opportunity lost nationally to not take advantage of the knowledge and resources of the state chapters. We did a membership drive in California where when we would have a lapsed member, it took forever. It took like 5-6 years for ACEP to even share our membership information. When they finally did, we would look through and see, okay, these are our lapsed members. And almost all the time, I had a board member who had a personal relationship with one of the lapsed members, and we would call them and say, hey, what happened? Why did you cancel? Could we get you to rejoin? And the state chapters have that relationship and have that knowledge, and I think we're not leveraging it the way that we should.
Yeah, and that was like I said, that was a bit of a loaded question because although I feel like ACEP when I asked them would be fairly helpful, they just seem, I think they seem disconnected from a lot of the state issues, like they said, and they're very focused on the federal issues, which I understand. I mean, that's, you know,
Yeah,
someone has to
that's
fight
their
that
job.
fight. But sometimes, you know, I don't know. I personally, just from my standpoint, I like when I see a state chapter president who is really deeply entrenched in their state issues and understands the fight of their state issues going on to national. That appeals to me because that's, I hear that you get it. You know what we're going through. You know, you're not well, I don't know. You're at UC Davis, right?
Yep.
Are you actually an employee? Are you an employee of the state of California?
Technically, yes. So I work for the University of California and I'm a state employee. Yes, technically.
Okay. So you're not a contract management group that contracts with the state of California?
No, no.
So did people ever say to you, they're like, you're an employee of the state. So why do you care about all this balanced billing stuff? Why do you, because I'm an employee of a health system. I'm not a, and they're like, why do you care? And I'm like, because I do, because it's wrong, you know?
Because I care about the specialty, because I love our specialty.
I know. Right.
Yeah, so I have fought, you know, my whole career for balance billing, and it really does not affect me at all.
Right.
I mean, on some level it does, right?
Boat.
Because we're all in the same boat together, so we sink or swim together. So, you know, we're all part of the same boat, but it doesn't impact my practice as much as it does my colleagues. But I have spent my whole career working with them and fighting for them, so I really understand the challenges because I've spent so much time in it.
And that's the argument I would make with my colleagues would be that, you know, even though this doesn't impact us immediately, we're not, Cameron's part of a Democratic group. I used to be part of a Democratic group. You know, whatever everybody else is making around us, whatever everybody else is getting reimbursed does impact the market pay. And so, you know, if the market pay for all the Democratic groups in our area and all the contract management groups in our area goes down, guess what? Ours is going to go down too. So it does impact us.
Yeah. Well, it's just, it's resources available to take care of emergency medicine patients.
So along those lines, you know, the loaded question here, how do you feel that the impact of the contract management groups? I heard you talk about there's a special time for sort of emergency medicine to take back our practice and to take back our reputation and all that. And I feel that that's the case also. And I also feel like there's a bit of an opportunity for doctors to take back emergency medicine from contract management groups to some extent too. And I don't know if that's what was included in your in what you were saying. And I know you're going to have to tread lightly here, but you know, what are your thoughts on the influence of that nationally on ACEP?
Well, I don't know if you remember, but I ran the private equity resolution last year.
Was that you?
That was me. Yes. So that was my resolution. Good. For some background. So I think, you know, we have a really pivotal moment in terms of who has agency over our lives and our practice. And the pendulum has swung too far, and that we don't have agency over our practices. And we need to take that back. And really, it's as an organization that represents emergency physicians, that ACEP should be very clear about who they're fighting for. And so they should always think about, does this benefit the emergency physician? And if it doesn't benefit the emergency physician, we shouldn't be involved as an organization. I also think within ACEP, one of the things that I've never liked, and I noticed this even in my state chapter, is we kind of have these teams. They're almost like sports teams' allegiance to your employer. And I think that distracts from the greater issues, like that we should come together and talk about hard topics, controversial topics, but we can do it if we put aside those allegiances and think about, hey, what's best for the specialty? You and I do this when we say, I really need to fight balance billing. I need to fight for fair reimbursement for my colleagues, because that's for my specialty and that's for my patients. Like, we need to have resources to take care of our patients, and it shouldn't be about who you work for. And that kind of team division really distracts from the greater mission. I mean, I think that we're in a time of change, that we're an inflection point, and we're going to have to talk about some really challenging topics. And I feel like I've been able to do that with the private equity resolution, to like bring forward things that we had not been talking about and to bring it up and to kind of build some consensus.
Right,
The
Cameron.
private equity, I think in our chapter, the people who worked for private equity had the strongest response to that, and tried to make it so that we could use folks like me who has no interest, Todd, our immediate past president was a small Democratic group, to speak for them so that they didn't have to worry about repercussions. And I think that that's where national ACEP can protect some of those people as well.
Yep. Yeah. No, I wholeheartedly agree. I just, there was one of those other moments where it was something that had bothered me for a long time. And then everything that happened that summer, I just felt like I had to push it forward. But I really wasn't sure how it would be received, but I felt like it was the thing that we had not been talking about for years, that we'd been whispering to each other, that we had talked about in behind closed doors, but had not talked about as a group. So I was actually really surprised and pleased to see the good response that it got. And so it really taught me, like, hey, we can bring up these things and we got to talk about them as a family.
I have not seen anything quite like that at council in a while, where, you know, there was almost a bit of a coordinated effort to make it go away, you know, to refer it to the board for further study and to do this. And it was just like every attempt at rebuffing it, there was this murmur of, you know, you could tell everybody was like, you know, no, and it would just keep getting voted down and stuff like that. I thought it was kind of cool. You know, you hit the nail on the head. There was definitely, everybody in the room wanted to talk about it. Mm-hmm. And there was some effort to move us away from it, but everybody wanted to talk about it. Have you followed, so have you followed the progress of it since last council?
Yes. I mean, I knew when I started this that it would be challenging for the board to deal with, and
right.
They are moving it forward. They do have a work group. I am not on it. But I have been in contact with people who are in the work group, and they feel like they're making progress. They do have a proposal that they're going to put out to various groups to do this study. So I don't think that they took that football and said, yes, I'm going to run this all the way down the field, but they're doing it. So I very much think that the mission of ACEP is, one, to protect the emergency physicians, but also to take this moment when we have this huge public persona and we're going to start cashing in some of these chips. You know, they are a little bit in terms of talking about hazard pay and immunity, but I think at this moment, like, we got to cash in some of this public relationships and start talking about not just emergency physicians, but I've always found, like, I win so much more. Like, the way that I got the $40 million for California was talking about patients. And so if we shift this and say, hey, this was a public health crisis, and we are an essential piece of the public health system that has been underfunded, and you need to fund emergency departments for public health. And to really talk about, to raise up that conversation. And I think ACEP is the right place to do that. I mean, I think that what I would like to see on the board, what I think that I can bring to the board is, I am not afraid of controversial issues. I almost never take no for an answer, at least not until they've completely shut the door. I learned that from my state chapter, that you hear no about 100 different times, and that they will vote your piece of legislation down right before they vote it in. And so I will continue to push things forward, but then I think I can still bring consensus. Like, if we really focus on the specialty and our members, that we can work through some of these controversial issues and move us forward. I also think ACEP sometimes will lean towards nuance when really the issue is black and white. Like I think sometimes they'll think about the healthcare system as a whole and what is good for healthcare, when really I don't want them to do that. I want them to talk about emergency medicine. And the line should be a lot clearer when you think about the membership.
Do you have
And
any? Oh,
well,
sorry.
real
Go
quick,
ahead, Todd.
I apologize. My phone audio disconnected right when you were in the middle of your answer that I asked you about the progress of the resolution. So I can't wait to go back and watch this recorded video to see what your answer was. So, but I want, along those lines, do you feel like the board? So like if you were to take a guess, would you say that the current board would be excited about you joining them, or a little bit nervous about you joining them, or both?
I hope they'd be real excited about me joining them.
Good.
I've never been one to be quiet in a group. If I have an opinion, I've always been really good about pushing it forward, maybe to my detriment and to everyone around me, but no. I mean, I think the first thing is, one, to talk about them, to try and do it in a way that is direct, open, non-confrontational, so that, well, maybe a little bit, but so that we can kind of start to build consensus and change the way that we approach some of the issues. I've always been surprised at how much caution and nuance there is for a group of cowboys.
That's true.
Yeah.
I mean, you know, for who goes into our specialty and the rapid decisions that we have to make, I've always been surprised that we don't necessarily always bring that to our specialty organization.
How do you see oh, sorry, go ahead, Todd.
I'm saying I mean, I think that's a lot of because of who has been elected to the board in the past. And I mean, I think that there's been a lot of sort of political executive types that have been elected to the board rather than, you know, a lot of the bulldogs that rose up through the state ranks. And so I think that's partly why.
Yeah.
Not that they haven't done a good job. I mean,
No.
you know, I mean, ACEP's done a good job, but I think there's been that personality type isn't always as much there. So.
Well, and I just think this is why I'm running, because I don't think now is the time for nuance. That's
Right.
not the moment we're in. Yeah, I think that one, gosh, I love our membership because we, just as a specialty, have in an uncoordinated way really taken over the media. I love our members out there who are become the media darlings, which is really amazing because this could be the EMS workers, it could be the ICU, the nurses, but no, the emergency physicians have sucked up all the oxygen, and I love them for that. And it's really provided us this opportunity because really at no moment does the nation understand the value of emergency medicine and the value of having emergency departments open and able. We've demonstrated why you need capacity at the system, like why when we were overwhelmed and have zero capacity, that is bad for the nation as a whole. And so we should start to translate that into funding a public health system and funding emergency departments as an essential public service. I think it's hard because it's a little bit of a shift, but to start think about these public-private partnerships and for the states and the nation to recognize we need to have funding, not just to keep our doors open, but for there to be capacity in the system. You know, the thing that this really drove home, both in the surge capacity that we didn't have, but then the economic challenges of having a decrease in our volume, was how our business model, built on the margin of Medicaid patients that have been continuously cut, is a volume business. I mean, we run our emergency departments like a hot Sunday brunch place. If there's not a line out the door, we can't keep the doors open. So I think we need to start talking to the country about how that's unsustainable and unhealthy for the nation. Yeah, so my understanding, and I'm not from, you know, certainly California is not representative of the average chapter, that a lot of the smaller chapters feel well supported by ACEP, that over the years, ACEP has done a better job with the smaller chapters than the larger chapters. I think that there needs to be better opportunity for the state chapter leaders to learn from each other, because I think that there's a lot of innovation that happens at the state chapter, and that I know there's some conversation at the executive director level from my own executive director, but I think that that state to state knowledge needs to be more robust, because I think the issues of running a large national organization don't always translate into the state organization. So the best way for the state chapters to thrive is to learn from each other. And I often felt like if I was in a more robust network of state leaders, we would have an opportunity to learn more from each other. Does that make sense? Like,
Yeah.
we talk California to national. We don't talk California to Virginia. And so those connections, I think we would really do a better job of learning from each other. Because how you interact with your state government is different than how they interact with the national government.
Correct.
Mostly, you know, two things. One is, I think, kind of shifting the conversation. I'd like to see us, again, as I mentioned before, have less nuance and be a little more dogmatic in how we protect our emergency physicians. And two, to do a better job of kind of reaching out to the states to kind of bring in leadership. I think that there's a little bit of a separation between the state leadership and then the national leadership. There's so many folks who are involved on national committees. I would like to see us kind of merge those two a little bit more and kind of reach into the states more to find national leaders. ACEP should reflect its membership. So California ACEP reflects its membership. So for instance, a lot of the social issues that my chapter brings to national are not controversial amongst my membership, that within California, there is consensus on some of these issues. We're out there on the left coast. And so as a chapter, we bring the things that we have consensus over. And I think that's kind of the role of the council, is to learn where the membership is. So where there is consensus amongst ACEP members, that's where ACEP should be. So on one of my other resolutions that I brought forward was around extreme risk protection orders for firearms. That actually, we were able to build consensus. So that was a co-sponsored resolution with the tactical medicines section and the government services section. So we were able to say, okay, there are lots of places where there's controversy, but the places where there's not, that's where ACEP should be. So on that, I think, you know, ACEP should reflect the membership. And council, we talk about a lot of things and we learn from each other, and it can be messy, as is democracy. And that's what I like about it.
Good answer.